Okay, so this next talk is about breast MRI and the newly diagnosed breast cancer patient, and it will actually nicely dovetails with what Bonnie was talking about, so I was kind of happy about that. No financial disclosures, sadly, and no conflicts of interest. All right, so in this session, we're going to talk about the uses of breast MRI in the newly diagnosed breast cancer patient, benefits and controversy, because there still is some controversy, and then how could we maybe optimize use if we desire to do that. So MR is really best at lesion size. It's far more accurate than either mammography or ultrasound. And I just have an example of a case, and I don't know if we need to turn the lights down a little bit, it might help. Thanks. Okay, thanks. So this is just, you can see this patient looks normal. She's dense, has dense breasts, but the mammogram really looks quite normal. She comes in with a palpable abnormality here marked. And we do an ultrasound. We're quite proud of ourselves. We find this lesion. It's 1.3 centimeters, but look at the surrounding tissue. Looks okay. She's got an enlarged node. We stuck needles in both, and this is positive for invasive ductal carcinoma and metastatic to the node. But then she went to MR, and I don't think you need a scale to see what's going on here. Here's our clip, and there's way more disease. And actually, if we go to a next slice, oh yeah, there's more. And next slice, yeah, it's not looking good for us. And there's the MIP. So, you know, we really underestimated this patient's disease on conventional imaging. So it is best at lesion size, and it really outdoes both mammography and ultrasound. Now, the other use is that it finds tumors. It often can find tumors that are occult on either mammography or ultrasound or both. And I have several examples. So here's a lady who has a really complicated mammogram. This is the T2 weighted MR, and you can see she's got cysts all over the place, masses galore, very dense. And we saw a little area of distortion in her right lower inner breast, and we were proud of ourselves for that. And that's the mass right here, really easily seen with MR, and we biopsied it with ultrasound, and that's why she's having the MR, because that was invasive disease. But also on MR, here in the 10 o'clock position of the right breast was another mass that we didn't appreciate on the conventional imaging. We did end up being able to see it with ultrasound after the MRI, and it was another focus of malignancy. It was multicentric disease using ultrasound-guided biopsy with MR help, obviously. And this lady, I wish I had the mammogram on because it's striking. She's just a fatty mammogram with a group of calcifications in her central breast. We did an MR, and you can see this clumped non-mass enhancement that extends to and includes the nipple. And this was completely silent on conventional imaging, but obvious on MRI, and her nipple was involved at pathology. Additional lesions classically, now this is older data, I'm going to show you more updated data later, but the original study from Hosami looked at 19 studies. A larger meta-analysis from Plana of 50 studies showed that additional lesions are seen on breast MRI about 16 to 20% of the time. This is additional lesions, not necessarily additional cancers, but the studies were pretty consistent that the PPV was about 67%. So about 2/3 of these are going to be malignant, based on the classic older studies. Now, I mentioned that MRI can find tumors not seen on mammography and ultrasound, and Bonnie brought this up as well, and I'm just going to cover it a little bit further. Search for primary is a very good use for MRI in these patients, and here's a patient with dense breasts. She presents with a palpable axillary node, and we could not see it on mammography. You could see it here, the node, and here on MR, and MR easily shows the tumor in the posterior left outer breast. So occult primary tumor, but obvious on MRI. And I have a couple of cases just demonstrating the same principle. This was an outside case that came to us when I was in Texas, and this lady had presented to an outside institution with this enlarged axillary node. Her mammogram looked normal in both views. She came to us for MRI because here's the CC view looking absolutely normal. And then they excised the node, which is not the optimal thing to do. It's better to just put a needle in it, but they probably just didn't have that capability. But anyway, they went in and cut out the node, found out it was metastatic disease, and then sent her for breast MRI to our facility. And you can see the breast now is pretty angry. There's a lot of post-operative edema. She has a bunch of axillary adenopathy, actually, so she's got a bunch of matted nodes there. And then on MR, we see this enhancement. And you can see pre-contrast, there's nothing going on. This tissue looks like it's minding its own business, but when you put the gadolinium in, then you get to see the invasive malignancy that accounts for her adenopathy. And this one I like to show because, we live and die by our technologists. I love my techs. What we do really depends on them. And this lady came for screening, and she had frozen shoulder both sides. I know what that feels like. And the tech was really trying hard, and this was the best she could do on the left. She did get pecked down to nipple, although she didn't get as much as she wanted. This side was just stubborn, so she said, I'm just going to yank that breast in and get a little bit more, and that's what she got. So here's this big lymph node. So we brought her back, big lymph node on ultrasound, and this was needle biopsy was positive for metastatic breast cancer. So then she goes to MR, and here's the subtracted images from the contrast series. Here's the clip in the node that we biopsied. And then if you look here, just at nipple level, there's a small enhancing mass, which we believe to be her malignancy. Now, I mentioned that MR finds things that are occult on conventional imaging, but so far I've shown you ones that could still be seen with ultrasound. But we did targeted ultrasound, and we knew where to look, and we still could not find this lesion. So this was occult to both mammo and ultrasound, and so we went back and just did an MR biopsy. You can see a sampling here, and this was invasive ductal carcinoma. Okay, so MR is quite useful in finding additional tumors and a search for primary. The other use of MR in the newly diagnosed breast cancer patient is to really look at the tumor environment and its effect on the surrounding tissues. And so here I'm showing T1 non-fat sats, one of my favorite pulse sequences because it's good for anatomy, showing nipple retraction. In this patient, different patient with skin retraction. These are going to be obvious clinically, obviously, but you can see them on MR as well. Here's a patient, and what does she have? She has asymmetric nipple enhancement. This is Paget's disease, and obviously we knew she had Paget's, so we were looking for the underlying lesion. Paget's is always staged by the underlying lesion because nipple involvement does not change stage. This is in situ Paget's because we could not find an additional invasive lesion to account for it. This patient also has Paget's disease, but she has a large underlying tumor, so that's what's going to stage this patient. So the question, though, becomes, what about skin involvement? Nipple involvement is different than skin involvement. Skin involvement does change stage. So this lady had multicentric disease on the right. This is the right breast. You can see she's got a lot of edema on this T2-weighted image. She has a lot of skin thickening. But the question is that involved? Sometimes it's just lymphatics are overwhelmed at the axilla or whatever, and it doesn't mean the skin is involved. You want to look for enhancement, and in this case, you can see the enhancement here along the medial skin, not just hypervascularity, but true skin enhancement. So it doesn't matter what size the tumors are. This makes it an automatic T4B, which makes it stage 3B disease. So even if it's a smaller tumor elsewhere in the breast, skin enhancement ups the stage. This is a large tumor here on a sagittal, and you can see it extending into the pectoralis, the edge. We caught it here, and you can see the pectoralis muscle enhancing. And as Bonnie mentioned, this is not, the pectoralis for staging purposes is not considered part of the chest wall because it's treated differently. So it doesn't affect the stage, but it does affect what the surgeon needs to do. So here's another tumor abutting the pectoralis. And you can see there's obliteration of the fat plane between the tumor and the pec, but the pec is not enhancing. You need pectoralis enhancement if you're going to call pectoralis involvement. In this case, I tell the surgeon it abuts the pectoralis muscle, so they know they're going to have to probably take down pec fascia. But this is not pec involvement yet, and then that'll come out at the surgery. But chest wall involvement, that's a different thing, and that's other than the pec. This is, you can see a tumor embedded in the chest wall musculature and this right off the inframammary fold in this patient and into the intercostal muscles. And chest wall involvement does change the stage. So any tumor that has chest wall involvement is going to be a T4A, and it'll be stage 3 disease. Okay, so we have accurate tumor size, occult tumor depiction, and also whether or not we have skin, chest wall, nipple, or pec involvement. All can be determined on with the use of MR, And 2 of these, like I said, skin and chest wall, directly affect stage. So this allows for effective treatment to look at the tumor environment so that the surgeon is ready for what they need. And this overall results in very accurate staging for the ipsilateral breast. So that's the first use of MR in the newly diagnosed breast cancer patient, is accurate staging. The second thing is contralateral surveillance, and we know that between 3 and 9% of patients will have disease in the other breast, and that's called a synchronous contralateral breast cancer. So this patient has a normal mammogram other than this mass in her left posterior superior breast. It was diagnosed as malignant, and she went to MR. And on MR, you can see the lesion here. It's centrally located, but unexpected, you can clearly see the contralateral right breast cancer. As I mentioned, the range is about 3 to 9. This meta-analysis came up with overall about 4% of patients will have a synchronous contralateral breast cancer. In addition, if we remove these, then you would expect that there are fewer metachronous contralateral breast cancers in patients who have had MR, and this was actually found to be true. This study by Kim and Associates showed that patients who had MR had fewer metachronous contralateral tumors. So there is benefit, so we're decreasing those as well by removing them early. All right, so in addition to accurate staging and contralateral surveillance, evaluation for neoadjuvant chemotherapy is another use, and I know Bonnie talked about this as well. You can see this is the patient I just showed you. Here she is post-chemotherapy, very easy to tell that she's had a good response. Now, could you do this with ultrasound? Sure, but trying to look for nothing in a big breast at the chest wall on ultrasound, it's a bit challenging and time-consuming. This is easy, right? You can just look at this and see she's had a response. Same for this patient who's had a partial response. Here's pre-chemo, here's post-chemo. It's a partial response, but if you're using ultrasound, you got to really make sure you're in the right scan planes so you can assess that difference. But here, it's just dead obvious on MR. So it's an excellent use of MR in patients with new cancers. Now, I will say, though, MR is useful, but the literature is difficult to interpret, and that's for several reasons. I think Bonnie's work on the I-SPY trial and those kind of things are really needed because to date, it's really hard to look at these different studies because there's not a great control for different treatment regimens, and just the definitions vary, but also many of these studies are not controlled for tumor size, grade, or histology, which obviously would affect the results. So I think it's hard to quantify, but clearly I think MR is useful, but the degree of that usefulness, we really need more quantitative data to discover that. All right, let's talk about the benefits and controversy. So I mentioned MR-only disease. We said there are additional lesions, and with the PPV, we have additional malignancy in the classic older studies of 11 to 14%. But we have newer data from the US, Germany, and Canada, all large studies, showing additional malignancy. Now, these are proven malignancies now because we're using MR biopsy more, between 14 and 34%. So we're seeing disease that we have better MR technique and better interpretation. So we see additional lesions in up to 45% and additional cancers in up to a third of patients simply by doing MR. Now, there is a whole host of people out there, mainly surgeons, but some radiologists too. If you ask them, are these additional lesions important? And there's a cadre of people who will say no. You know why? It doesn't affect the stage. And it doesn't help with surgical management. You know, we're going to clean that up with radiation and chemo. And actually, it's not an unreasonable argument to say, look, we never knew about this disease, and yet we studied lumpectomy versus mastectomy, and the survival's the same. So clearly that disease was there. It's not changing survival. You know, what the heck? There are a lot of radiologists that were mad at the surgeons for saying that, but you know, it's actually a pretty cogent argument. So the question is, you know, really, let's take a deeper look at what we're doing. So first of all, are the additional lesions important for staging? Well, not if you use the TNM system, because the T is only determined by the largest lesion, right? So this lady who has maybe a 1 centimeter or 1.9 centimeter tumor, her T is the same as this woman who has 10 tumors, but the largest one is 1.9. So that's a failing of the system, all right? The survival might be the same for these, but the management generally is not. Now, the TNM staging system was started in 1959 in the absence of screening mammography, in the absence of effective chemo and really with very little knowledge of overall tumor biology compared to what we know today. And up until 2017, that staging system that we all use didn't even account for tumor grade, receptor status, or multifocal and multicentric disease, which I'll just call multi-disease for ease. But, you know, we used them all the time. I mean, when I was a fellow 30 years ago, we took into account ER, PR, and if it was a high-grade tumor, the surgeons treated it differently. But it wasn't part of the prognosis, which is kind of silly if you think about it. But this system is very slow to change. And in 2017, these were added, tumor grade and status, but multi-disease has not. But I think it should be, and this is a very good study. It's hard to get this kind of study, so we don't have a lot of different studies. But this is a very long study, fairly large, comparing two groups, unifocal disease and patients that had multi-disease. And they were matched for not only the size of the tumor, but grade and hormonal status. So that's very hard to get. And what they found is that if you have multi-disease, your chance of local recurrence and distant metastasis are significantly higher, and your relapse-free survival and overall survival are statistically lower. So multi-disease is important. They found that having multifocal or multicentric disease was an independent predictor of breast cancer-specific survival and relapse-free survival, and neither of those is really surprising. So for those who say, well, look, it doesn't change prognosis, well, it's because the prognostic indicators need to be updated, just like grade and biology markers. Now, there's also people that say it doesn't help with surgical management, and that was based on early studies. This was a meta-analysis of 9 studies showing that whether you had MR or not, the re-excision was the same, but you were much more likely to have a mastectomy. And people looked at that and said, well, that's not good. Surgeons just said, we don't want to be forced into mastectomy on these patients. But you have to look at newer data, and studies started to come out in 2013 and beyond. And this one, it's a small study, but shows that if you had an MR, your positive margin rate is half of what it is if you don't have it, and the reoperation rate is also about half, both statistically significantly better with MR. And I like this study from Janice Sung, who's going to be speaking at this conference. This is one of the few studies that control for the surgeon. If you think about re-excision rates, the surgeon's a pretty important variable. And they found that with MR, re-excision rates were significantly better than without. And then this study is a randomized trial from Sweden. Young women, they did lack MR-guided biopsy, but it benefits from a randomized design. And what they found was that the MR group had a better overall reoperation rate compared to the no MR group, especially if they were planning to try to conserve the breast. Very significantly different using MR. The overall mastectomy rate, by the way, was the same whether they had MR or not, and the time to treatment was not hurt. So the fact that the early studies said it didn't help with surgical management really has not turned out to be true over time. So that really needs to be updated. There is evidence that MR is beneficial to the surgeon. All right, so how could we optimize the use? This got me thinking about, who should you be using MR on? And as one of the other speakers mentioned, I had surgeons in Texas that got MRs on everybody, and some that got them on nobody. And the everybody person kind of was not my favorite thing to be doing, because when I opened up an MR scan and I was looking at an 86-year-old for extended disease, you go, okay, I just gave 86-year-old kidneys gadolinium. That's great. So you don't really want to be doing everyone, I don't think, but you might. But there are ways to think about optimizing use. And so I started thinking about that. It is an asset in the newly diagnosed patient, but it does benefit some populations better than others. For example, patients with invasive lobular carcinoma. We know that conventional imaging has difficulty outlining this disease process. And there's long studies, I gave you lots of the references, that you can use MR and reduce the reoperation rate for ILC by 40% without increasing the mastectomy rate. So obviously, that's a benefit for that biology. So it got me and other people thinking, what about other biologies? What about other factors? Maybe there are things that we can look at. So we're going to go through a series of studies. This is from the Netherlands, and they asked the question, who's most likely to have additional disease at MRI versus conventional imaging? And they found young age, node positivity at the onset, HER2 positive disease, a tumor size discrepancy between mammo and ultrasound of a centimeter or more, or ILC. You're going to be more likely to have additional disease. And even at multivariate analysis, these all persisted except HER2 positivity. And they found there was significantly more tumor discrepancy for young patients and dense breasts. So this is going to be a theme we're going to see over and over. So they said if you have any one of these, you ought to do an MR. Age under 60, dense breasts, node positive, size discrepancy, or lobular histology. And then they went back and said, what if we applied these to the cases we already have? What would have happened? Well, you could decrease the number of MRs you were doing by 20%, but you're also going to miss 7% of the additional cancers. So there's a cost, but you could decrease MR use that way. This is from Germany, large study, additional cancers in about a quarter of the patient. Who was most likely to have additional disease? Premenopausal, so young, ILC, dense breasts. What do we do if we apply that retrospectively? We decrease MRs by 32%. They didn't outline how many malignancies would be missed. Okay, they didn't find any effect of HER2, but this study by Grimm at Duke looked at HER2 patients, and they found that they had more multi-disease and more lymph node metastases, so it was found to make a difference, and they included those in the people that should be considered for MRI. This Korean study looked at triple-negative breast cancer. Again, another tumor biology that's very aggressive, and what they found is that independently associated with recurrence was not having an MR or having dense tissue. So again, here's a biology where MRI can be helpful. And then finally, this is from Canada, and they looked at tissue density in MR. They found more disease in dense patients compared to fatty. It's 5x. But if you just look at all the dense patients, it's 2x compared to the non-dense patients. Interestingly, they found occult disease in about a third of the fatty breasts. I'm not sure what's going on there. I can't explain that one. Okay, so this tells me that there are subsets of patients who could benefit, who best benefit from MRI. And what are those? Well, there are certain tumor biologies, like invasive lobular carcinoma, like HER2 positive, like triple negative disease, aggressive disease, or those that we have difficulty with on conventional imaging. So certain tumor biologies, to me, that's a flag. I almost always do MRs on patients with ILC. Okay, young age, and I use 65, not 60, because 65 is looking younger and younger. And dense breasts. So there are patient characteristics. So patients who are younger, or patients who we have difficulty with on conventional imaging, these patients deserve, I think, a look with MRI. So we use this in Texas to steer for the surgeons to make them more comfortable with the patients that we were directing toward MRI. And then finally, there are certain clinical scenarios. Like if we know we have difficulty and we have a discrepancy between mammo and ultrasound, size discrepancy, we know that that patient is more likely to have multi-disease, and also patients that present out of the box with a positive axillary node. So just for surgical planning alone, a lot of surgeons want that anyway, but there's good basis for it because these are the patients that also are more likely to have more tumor than you suspect on the first go-around. Okay, so disease occult to conventional imaging has been controversial, but I'd like to alter that and say it's important. So you can't just ignore it, which is what the surgeons originally said. Look, I don't want to see that stuff. Don't do the MRI, don't show it to me. Well, that's just not realistic. Patients want it, and there are many surgeons who are using it routinely. So we've got to find a way to manage it. Now, one way is our own interpretations. We can't biopsy everything that looks like a dot. So you have to get comfortable reading so that we're not overcalling on MR, but we have to be prudent, I think, on how we use it. And there is a way to discriminate so that we target MR where it is most useful. So to summarize, the uses of MRI in the newly diagnosed breast cancer patient, it results in very accurate staging. There is a benefit of contralateral surveillance, and it's useful in the neoadjuvant setting, as we showed. There are benefits as well as controversy. Additional disease is not uncommon, and we're finding more and more with better technique and better skill at it. I think the prognostic indicators need updating. We really need to recognize the importance of multifocal and multicentric disease. And we've seen that with recent look at literature, we really are helpful with surgical management. And then finally, there are ways to optimize use, looking at parameters for who benefits most. Tumor biology, such as the aggressive tumor biologies we talked about, triple negative and HER2 disease and ILC, patient factors, density and age, and then finally certain clinical scenarios like node positivity and discrepancy on conventional imaging. Thank you very much.